Hello guys, today I will discuss lupus nephritis, which is very important topic as a clinical case as well as for the exam point of view. Firstly, the systemic lupus erythematosus. Let me switch on the pointer. So systemic lupus erythematosus is a multi-systemic disease in which there is production of the autoantibodies and immune complex formation. So the injury in the cell is caused by the deposition of the immune complex and the binding of antibodies to the various tissue. There is loss of self-tolerance to the nuclear autoantigen that resulting in the formation of autoantibodies. So this is the criteria for the systemic lupus erythematosus. There is clinical criteria and there is immunological criteria. These are the components of the clinical criteria and these are the components of the immunological criteria. So what is the mechanism for the immune complex deposition in the lupus nephritis? So immune complex mediator is type 3 hypersensitivity. So there is binding of autoantibodies to the autoantigen that is implanted in the glomerulus. There is binding of the autoantibodies to the intrinsic glomerular antigens and there is deposition of the preformed circulating immune complexes. So the lupus nephritis constitutes one of the most severe organ manifestation of the SLE. So it developed within 5 years of SLE diagnosis, although it can develop at the later times. So in many cases, patient present with the lupus nephritis. After that, we work up for SLE and then we make the diagnosis of the SLE. So in many cases, lupus nephritis is the presenting manifestation. There is greatest risk of morbidity and mortality. So what is the role of kidney biopsy in the lupus nephritis? So kidney biopsy gives information about the class, severity, activity, chronicity, and which can't be accurately predicted on the basis of clinical background. What are the indication of the renal biopsies? There are ACR guidelines, there are CRIGO guideline. According to the ACR guidelines, if there is increasing serum creatinine or there is confirmed proteinuria more than equal to 1 gram per 24 hours, there is combination of the following, that is proteinuria more than equal to 0.5 gram per 24 hours plus hematuria, or there can be proteinuria more than 0.5 gram per 24 hours plus cellular cast, or we can do repeat biopsy if there is no response to treatment or there is deteriorating renal function. So this was the ACR guidelines. Now CRIGO guidelines. If there is impaired renal function, there is hypertension, there is proteinuria, and there is active sediments. So this is one article on the revision of International Society of the Nephrology classification for the lupus nephritis. So clarification of the definitions. So for class 2, definition of the mesangial hypercellularity adjusted. Four or more nuclei fully surrounded by the matrix in the mesangial area, not including the hilar region. So for class 3 and class 4, the term endocapillary proliferation is replaced by the endocapillary hypercellularity. The term crescent is used for the lesion consisting of extracapillary hypercellularity composed of various mixture of the cells that can be fibrin and fibrin matrix. There can be 10% or more of the circumference of the Bowman capsule should be involved. Or there are three type of crescent that can be cellular crescent, fibrous crescent, and fibrocellular crescent. More than 75. So the cellular crescent is when there is more than 75% cells and fibrin, and there is less than 25% fibrous matrix. Fibrocellular crescent is when the cells and fibrin percentage is 25 to 75 and the remaining is fibrous matrix. So, what is fibrous crescent? When the fibrous matrix is more than 75% and the cells and the fibrin are 25%. These are the definition of cellular, fibrocellular, and the fibrous crescent. So, definition of the adhesion, the area of isolated continuity of the extracellular matrix material between the tuft and the capsule when even when the underlying segment does not have overt sclerosis. This is the definition of adhesions. Fibrinoid necrosis, the fibrin associated with glomerular basement membrane disruption and or lysis of the mesangial matrix, and this lesion does not require the presence of karyorrhexis. So these are the recommendation for the definition of various terms like mesangial hypercellularity, endocapillary proliferation, which is replaced by the endocapillary hypercellularity. Now we use the term endocapillary hypercellularity. There are three type of crescent: cellular, fibrous, fibrocellular. Their definition: percentage of cells and fibrin in them. The definition of adhesion, definition of fibrinoid necrosis, and the definition of the crescent. So there are the 1 to 6 class of the lupus nephritis. So now I am explaining class 1. So the class 1 is minimal mesangial lupus nephritis. So there is glomerulus with no significant mesangial hypercellularity. On immunofluorescence, there is focal mesangial trace to 1 staining for the immunoglobulin G. On the, you can see the He staining, no significant mesangial hypercellularity. This is the immunofluorescence. There is focal or 1 plus staining for the IgG. On the electron microscopy, there is glomerular capillary with the normal basement membrane, preserved foot processes showing small granular mesangial deposits. And next they have presented one diagram. In the class 2, there is class 2 lupus nephritis. We say mesangial-proliferative lupus nephritis. So there is glomerular with mild focal mesangial hypercellularity. We can see here there is mesangial hypercellularity. As we read earlier, the definition of the mesangial hypercellularity: 4 to more than the more cell. Now it's not going back. 4 to more cells. On the immunofluorescence, we see two granular staining for the IgG, restricted to the mesangium. Mesangium. This is the mesangium. In the electron microscopy, glomerular in the electron microscopy, glomerular mesangial area with the fine granular dark deposit, a fine granular dark deposit admixed with pale matrix and cells. There is normal glomerular basement membrane reflected on the mesangium. In the electron microscopy, we can see the glomerular basement membrane is normal, but in the mesangial area, we can see the finely granular, darkly electron dense deposit admixed with pale matrix. Admixed with pale matrix. In class 3 and 4, 3 is focal, 4 is diffuse lupus nephritis. Focal means if there is involvement of less than 50% of the glomeruli, total glomeruli. Diffuse is involvement of the more than 50% of the glomeruli. More than 50% of the glomeruli. So, as I said, class 3 lupus nephritis is focal, class 4 is diffuse. So, we can see here glomeruli 1, 2, 3, 4, 5, 6. Out of 6 glomeruli, only one is showing mesangial hypercellularity. We can see here there is sclerosis, mesangial hypercellularity. Only one of the glomeruli is showing out of 6. So, number of glomeruli involved is less than 50%. So, we can call it as a focal lupus nephritis. And we can see in class 4 lupus nephritis, there are 1, 2, 3, 4, 6. One small one is there, 7, 8. So there are more than 50% of the glomeruli are involved. So we will say the classes class 4 or diffuse lupus nephritis. This is the activity and chronicity index we calculate. So in the activity index, we can say there is we calculate endocapillary hypercellularity, neutrophil or karyorrhexis, fibrinoid necrosis, hyaline deposit, cellular fibrocellular crescent, interstitial inflammation. There are 6 points we calculate, and in endocapillary, and the total score is 24, and the maximum score is 3. So endocapillary hypercellularity, we calculate less than 20%, 25 to 50%, more than 50% of the glomeruli. If endocapillary hypercellularity is present in less than 20% of the glomeruli, we will give the score of 1%. If it is present in 25 to 50% of the glomeruli, we will give score of 2%. And if it is present in more than 50% of the glomeruli, we give the score of 3 plus. So, final score will be given as 0, 1, 2, 3. Maximum score is 3. Next is neutrophil or karyorrhexis. If we see neutrophils or karyorrhexis in less than 25% of the glomeruli, we will give score 1 plus. When we see the neutrophils or karyorrhexis in 25 to 50% of the glomeruli, we will give the score of 2 plus. And in the more than 50% of the glomeruli, we will give the score of 3 plus. Similarly, fibrinoid necrosis is calculated. less than 25, 25 to 50, and more than 50%. Now we will see the hyaline deposits. There can be wire loop lesions or hyaline thrombi in less than 25, 25 to 50, more than 50% of the glomeruli. We will check for the cellular and fibrocellular crescent. If there is cellular and or fibrocellular crescent in less than 25%, score 1 plus, 25 to 52 plus, more than 50 is 3 plus. Now, last one is interstitial inflammation. If interstitial leukocytes in the cortex is less than 25%, then score 1 plus, 25 to 50 is 2 plus, more than 50 is 3 plus. We will check in the cortex. So these are the parameters. There are 6 parameters and the total score is 24. Now coming to the chronicity index, the total score is 12 and there are 4 parameters. First one is total glomerulosclerosis score. Second is fibrous crescent, then tubular atrophy and interstitial fibrosis. In the activity, we calculated the cellular and fibrocellular crescent. But in the chronicity, we are saying the fibrous crescent. So the first one, total glomerulosclerosis score. Global or segmental sclerosis in less than 25 is 1 plus, 25 to 50 is 2 plus, more than 50% of the glomeruli is 3 plus. So what is global and what is segmental? So in one glomeruli, if more than 50% of area of the globe is involved, let me draw a diagram. This one I can use. So this is the glomeruli, and if more than 50, like this all portion is involved. So I will say this is more than 50%. I will say this is global sclerosis. This is global sclerosis. What if less than 50% of the area is involved? Like this much is involved, is sclerosed. So I will say this is, because this is less than 50. 50 will be about this, about this. So this sclerosed area is less than 50% of the one glomerulus. So this is segmental glomerulosis. Global I told more than 50, like beyond this line, more than 50 will be global. So this is global and segmental sclerosis. Next one is fibrous crescent. Next one is fibrous crescent. Definition of the fibrous crescent I already explained in the previous slides. So if the fibrous crescent is present in the less than 25%, it is 1 plus. 25 to 50 is 2 plus. More than 50 is 3%. Now we will see tubular atrophy. Similarly, like the fibrous crescent and the sclerosis, we will assess the tubular atrophy and the interstitial fibrosis. So the interstitial fibrosis and interstitial inflammation we will assess in the cortex. So we will give score. Hope you understand the activity and chronicity indices. This is the picture showing activity index endocapillarily hypercellularity with neutrophils. We can see in the neutrophils, there is neutrophils. There are so many neutrophils in the endocapillary hyper, causing endocapillary hypercellularity. And there is subendothelial hyaline deposit. We can see here subendothelial hyaline deposits, hyaline thrombi. These are the subendothelial hyaline deposits. We can see here. Now they have given the definition of the cellular crescent. We can see here there is crescent formation and there are more cells, like more than 75% cells and the fibrin. So this crescent is cellular crescent. This crescent is cellular crescent, and the crescent should be more than equal to two cell layer, more than equal to two cell layer thick. And next is fibrinoid necrosis. We can see this eosinophilic material, dark, deep eosinophilic material, that is fibrin. This is fibrinoid necrosis. Now coming to the chronicity index. Firstly, they have one first parameter is glomerulosclerosis. So we can see there is segmental sclerosis. This is pool. So this is pool of the glomerulus. Involve sclerosis is only this part, and this part is sclerosed. Means less than 50% of the part is sclerosed. So this is segmental sclerosis. Second one is fibrous crescent. Second one is fibrous crescent. We can see this crescent. There is more fibrous tissue, like more than 75% of the fibrous tissue, and less than 25% there is cells and fibrin. So we see the full house pattern in the class or lupus nephritis. We can see the full house pattern in the class lupus nephritis. That is all major antibodies and complement they show immunoreactivity. We can see IgG, IgA, IgM, C3 complement, C1q. They show the immunofluorescence. Then there is tissue ANA phenomena. So tissue ANA phenomena. There is another commonly observed phenomena in immunofluorescence studies in the detection of the tissue ANA in the renal biopsies. So they have said that although the ANA is detectable by the inject immunofluorescence during tumor cell line as a substage in up to 98% of the lupus patient, for unknown reason, only a fraction of the patient with lupus nephritis exhibit ANA activity in their own renal biopsies. So the reactivity consists of positive staining of renal epithelial nuclei. This is renal epithelial nuclei with anti-sera to the IgG in a homogeneous speckled or rim pattern similar to that observed in the serum ANA testing. So for they have said only a fraction of the patient with the lupus nephritis exhibit the ANA activity in their own renal biopsies, and we can see the positive staining of the renal epithelial cells. We can see here renal epithelial cells. Class 5 lupus nephritis is membranous lupus nephritis. There is thickening of the glomerular capillary membrane. We can see here. There is thickening of the capillary membranes. We can see. We can nicely appreciate these capillary. They are thickened. Normally, we compare this capillary basement. How we can compare that this is thicker? We can compare this capillary with the basement membrane of the tubules. We can see here this basement membrane of PCT. If we compare this glomerular capillary basement membrane, we can see here this is thickened as compared to this. And the normal basement membrane is about 300 to 400. Some books has written 250 to 450. It depends upon the age and gender of the patient. So Jones-Mitham and Silverstein, we can see the spikes along the capillary wall. If you can appreciate these small spikes, like threads like areas coming from the capillaries. We can see these threads. Okay, I will show here. Like this is the capillary. So there are threads like this. These are the spikes. These are the spikes. These are the spikes. Like here. Here we can see spikes upon the capillary walls on the Jones-Smith and Silverstein. So these spikes can be appreciated on the higher part. We can see here these spikes. So this is the full house, sorry, pattern in the class 5 lupus nephritis. This is the class 6 lupus nephritis. There is more than 90% of the global re-sclerosed glomeruli without residual activity. And this is the frequency of the histologic pattern in lupus nephritis. Thank you.